Good morning, everybody, and welcome to the last in this current series of our MDT Spotlight. I am, as always, just going to quickly share my screen at the beginning. Okay. Lovely. So yes, brilliant to have you here. Thank you so much for joining us. I'm really pleased that we are going to be focusing in this last session on the pharmacy specialty, and we have some amazing experts here to talk you through lots about the kind of neonatal specialism of pharmacy and where that fits in within the wider MDT on neonatal units. I'm Chelsea Letts. I'm the Healthcare Engagement Programme Lead at Bliss, and you will have probably seen my face a little bit on some of these sessions, but I'm really pleased to say that the experts here are Sian and Louise. So Sian, would you mind just introducing yourself, please?
Thanks very much, Chelsea. And thank you for inviting me, Louise, to speak today. So I'm Sian Gaze. I'm the lead pharmacist for medicines and neonates at the Evelina London Children's Hospital. And I've recently started a new role in London. I'm the lead pharmacist for the neonatal London ODN.
Lovely, thank you, Sian. And Louise?
Thanks, Chelsea, and thanks again for inviting Sian and I to be here today. So I'm Louise Bracken. I'm a senior paediatric research pharmacist at Alder Hey Children's Hospital, and I was the chief investigator for the Paddington studies as well. And I lead our paediatric medicines research unit at Alder Hey.
Lovely, thank you so much.
Thank you.
So before I hand over to Louise and Sian, I just wanted to share a bit about what our plan is for today's session. We are going to try and keep it to an hour. We know we've got a lot to squeeze in, but that's our plan. Keep it short and sweet today. Sian, I think, is going to give us initially a bit of an introduction into kind of neonatal pharmacy, where it all fits in, and then Louise is kindly going to give us a bit more information about the amazing Paddington study, and we will have opportunities during and at the end, hopefully, for some questions from you. We have had a couple come through from the registration form, so thank you for those. We will try and get to those. Please do pop your questions into the Q&A or the chat function that you can hopefully see on your screens now during the session, and I'll try and keep an eye on those and make sure that we try and answer as many as possible. But I just wanted to also highlight kind of, just as we're kind of bringing this particular series to a close, why we've really wanted to focus on each of the different specialisms. And obviously today, as we've said, is pharmacy. I think it's really important for us as Bliss to make sure that we're supporting you as healthcare professionals to think about the integration of the different roles within the neonatal team. And we know that that looks different in lots of different neonatal units. But how important all of these allied healthcare professional and psychology and pharmacy are in terms of the specialisms to the delivery of family integrated care for every baby. It's not something that can be done, as we know, in isolation, and actually all of the different MDT roles have a really important role to play in that. As I said, we know that it looks different in different places, so there are challenges around inequities of service, and that can have impact on how parental partnership looks on different neonatal units, but there's lots, I think, that we can learn from each other. So hopefully these sessions have been useful in trying to kind of shed light on some of that, and that's what we want to try and do today with pharmacy. So I will stop sharing my screen and pass over to Sian to give us a bit of a rundown of kind of neonatal pharmacy and what it's all about. So that'd be great, Sian. Thank you.
Thanks very much, Chelsea. Hopefully you can all see my screen. Currently mine is blank. Hold on, what have I done? 1 second. Try again. Here we go. That looks better. Oh. No, sorry about this, guys. 1 second.
No, don't worry, Sian. Take your time. We have just tested this, I'm sure.
We just did. Give me 1 second. What is going on? There we go. Right. Third time lucky.
Still blank for me at the moment. Would you like me to try? I think I've got your slides, Sian. Do you want me to see if I can try popping them up for you?
Okay, yeah, it's saying I'm sharing my screen, but no, every time I click on it, it goes blank. Sorry, I don't know what's going on now. We literally just tested this.
I know.
And it worked fine. It worked perfectly.
Difficult, isn't it? Hang on,
Thanks,
let
Chelsea.
me see.
There we go. That's me.
Is that all right? Let me just start it from the beginning for you.
Thank you very much.
Is that all right?
That is fine. Thank you. Sorry about that, everyone. So yes, I'll swiftly move on. We'll just move on to the next slide if that's okay, Chelsea. I'm afraid I'm going to be one of those people who says next slide, please.
That's fine.
So yes, a brief introduction to pharmacy, who we are and what do we do. So as you're probably aware, we are specialists in medication, and our aim is to ensure the safe and effective use of medicines in the neonatal population. And in conjunction with that as well, obviously, we do have to look at cost effectiveness as we are employed by the NHS. But the main goal is really to make sure that everything is safe and effective for our patients. We are involved in optimizing medication choice and dosing regimens. So things like, obviously, you're probably already aware that a lot of the medicines that we use in neonates are being used as unlicensed medicines or off-label. They're really designed potentially with adults in mind. So we might need to advise on which medicines are safest to use or how to manipulate those medicines to be administered to neonates, and on things like dose rounding and formulations. We provide education and training to medical colleagues, to nurses, and to other AHPs in the use of medicines. And our NPPG neonatology group is currently developing an educational training pack for neonatal pharmacists. We develop and maintain electronic prescribing systems. Again, a number of these are originally developed with perhaps adult patients in mind, and they're not necessarily adapted for infants, babies and children. So that is something that pharmacists are getting more and more involved with in the digital side of things, in making sure that these systems are made safe for our patient group before they're rolled out in neonatal units. And we're also involved with neonatal clinical governance, so in helping to, for example, write guidelines and manage risks and help to deal with incidents as and when they occur. Thanks, Chelsea. So a number of you might be very familiar with your pharmacist on the neonatal unit, especially when you are involved with prescribing or administering neonatal parenteral nutrition. Over the last few years, the move in the UK in particular has been towards standardising neonatal PN, and so more and more units are using standard bags now, but occasionally babies may require a bespoke PN bag, and that's where the expertise of the pharmacist in terms of knowing what is safe to go in the bag, how the bag can be adjusted or manipulated, what is safe to be maybe administered alongside the PN bag. That is where a pharmacist can really excel and be a very useful member of the team. We provide advice on initiation of medication, monitoring and review, and a number of us attend the multidisciplinary ward rounds. We ensure safe and effective supply of medicines on the ward, and again at discharge. And I know that Louise will talk a bit more of this in her section of the talk. We advise on therapeutic drug monitoring and adverse side effects. So a number of the medications we use, for example, in managing sepsis, are narrow therapeutic agents. So things like gentamicin, amikacin, vancomycin. It's really important that we make sure that these are delivered safely, that we monitor them carefully. Occasionally, babies might have issues maybe with their renal function, and we might need to advise on adjusting dosages or adjusting the frequency that the medicine is given at, or maybe adjusting the timing of when the levels are due to make sure that those babies are being bled at the correct time and those results can be interpreted and acted upon safely and effectively. And over the last few years as well, a number of us have undergone prescribing courses, are now employed as independent prescribers. So not only can we help advise on prescribing medications, but a number of us can now also prescribe the medications ourselves. Chelsea. Education is a huge part of what we do in the neonatal unit. We are often involved in helping to train and support, especially when the new junior doctors are inducted and the new nurses. We help to train nurses as part of their courses. We advise on prescribing and administration. We also are heavily involved in educating parents and family members on how to use medicines. And in recent years, again, the development of the Medicines for Children's leaflet has been a big step forward. So I'm sure you're aware that a number of the information leaflets that are supplied with medicines in the UK are designed, again, with adults in mind. So the leaflet may say something like, do not use in children, or do not use in people under 18. And immediately, obviously, that is going to alarm parents. And, you know, from that point on, really, the information might seem irrelevant to them. So we try and make sure that the information we supply on medicines is appropriate. And these Medicines for Children leaflet are very helpful in that regard. They are designed and tailored for parents and caregivers administering medicines to children. So we try and promote their use and make sure that parents are getting that correct information. And like I've mentioned previously, governance is again a big part of what we do on the neonatal unit. We ensure that the guidelines that are used are safe and effective. And this is being seen more and more now across the network as a number of network pharmacist roles are being created. So we're trying to standardise the way medicines are administered and prescribed across the network, as well as within the neonatal unit individually themselves. We are involved in assessing the suitability of medicines. So, for example, at the end of this month, the licensed potassium liquid that is currently available in the UK is being discontinued, and a number of units are looking at what could they potentially give as an alternative. So that is, again, where the pharmacist can show their expertise in terms of assessing, you know, the other excipients in the medicine. So not just the active ingredients, looking at things like the preservatives, the sweetening agents, the flavorings, just to make sure that what's in that medicine is actually safe for our neonatal population, because we do need to be quite careful with certain excipients. Some of them can potentially be harmful. We are developing systems to prevent medication errors, and we respond to events as and when they occur. So we help to investigate, look at the risks, and try and make sure that we minimise the risks of them happening again in future. And more hospitals are going towards using electronic prescribing systems. And like I've mentioned, pharmacists can be heavily involved in making sure that they are safe for the neonatal population. But also we're involved in making sure that drug pump libraries are safe and effective. So again, something that's happening in the UK currently is that we are trying to standardise the way that we deliver continuous IV drug infusions, and we're trying to align practice so that as many centres as possible are doing similar things, so that when babies are transferred from unit to unit, there's less risk of error. So that is something that your pharmacist can be really helpful in developing, is your local drug pump library, and then also potentially share that across your network so that everybody is using the same concentrations. And that is something, again, we're trying to promote nationally as well. And research is something that pharmacists can be involved with in your unit. So they might be involved in some quality improvement projects. For example, one of the posters on this slide here is a project that was done up in Nottingham, where they introduced a new caffeine product. But this medication, this was a cost-saving project, really, but this medication has no preservatives in it, so it has single use only. And so they introduced a system up there where they give the babies caffeine at exactly the same time every day. So every baby receives their dose at the same time, and therefore there's less wastage because only one bottle needs to be opened at a time, to avoid obviously opening multiple bottles throughout the day. That's just one example. There's lots of other examples of quality improvement going on in your neonatal units. And audits, again, is something that your pharmacist may be involved with. They might be involved in auditing against guidelines, for example, antimicrobial practice. This audit here, this poster, is from an MSc student from UCL who came to the Evelina for a few weeks, and she was looking at auditing our use of PN in babies who were older than 28 days, and whether or not we were following the recommendations on monitoring iron, trace minerals and vitamins. But again, there are lots and lots of examples of audits that neonatal pharmacists are being involved with, and that is something that you can get your pharmacist involved with if you're not already on your units. And that's the end of my section of the talk. I think Louise is going to deliver a few more slides, but does anybody have any questions they want to ask at this?
Thank you so much, Sean. That is such a helpful starting point. I think I learned loads there. I'm just going to have a quick check in the Q&A. If anybody has any questions, please do feel free to populate in there so that we can ask Sean and Louise. I think it strikes me kind of as you were talking through, Sean, that there's so much that happens probably actually in the background and kind of within pharmacy and that specialty, but how important it is that so much of that is done properly and kind of really thoroughly. I think I wondered whether there was kind of anything particular that you wanted to share about kind of how you see that working kind of with as a wider MDT to kind of support, ultimately try and kind of get families and babies the right support that they need to be able to obviously go home and discharge, and how as pharmacists you feel like that role, the role you play, kind of getting all of that right in the background first before that can actually happen. I wonder if you wanted to just say anything about that at all.
I'd probably like to raise one of my concerns almost, in that now we're moving towards electronic systems more and more. I find the pharmacists are maybe staying behind the screen a bit more. When we used to have paper drug charts, I'm sure some units still do, but we used to go to the cot side a lot more because we had to physically go to the cot side to look at the drug chart, which was next to the baby. And I think that's one of the dangers almost of having these fantastic electronic systems where we can review patients anywhere in the hospital, really. We don't even need to be on the neonatal unit, you could argue. You could be in a different part of the hospital. But it's really important, I think, that we do move away from that computer screen, that we do go and introduce ourselves to the parents. We explain the purpose of our visits and why we're there, and to check in with them and see how they're doing and find out if they've got any questions about their baby's medicines. And to promote ourselves, really, because I think you're right. I think a lot of the time we are almost ghosts on the neonatal unit, kind of sliding around in the background, chatting to the nurse, chatting to the doctor. But I think that it sometimes is overlooked by the parents because they don't, maybe sometimes they're not aware of some of these conversations we're having, you know, optimizing their baby's medicines, advising on their PN, making sure that the gentamicin level is being done at the correct time and it's being interpreted properly. So I think it's a challenge to us as neonatal pharmacists to take that step away from the screen and remember about the baby and the parent, and to make sure that they are aware that we are there and they can come and ask us for advice at any time.
Yeah, I think that's a really helpful thing to raise. And actually I hope maybe kind of those watching, if you are either, whether you're kind of a pharmacist or not, actually thinking about how this role is integrated into the team and can be parent facing and there with the family, the benefits that can bring as well, I think is really helpful. I think there's also, we've kind of obviously been chatting a bit ahead of this session, there was also a few kind of phy care practices that have been shared. I know we're going to talk a bit more about Paddington, which is a really lovely example of that. But I think, Louise, I don't know whether you want to share a little bit about your experience of working, I think it's with Liverpool Women's, isn't it? And kind of some of the practices that they might have that pharmacists are really involved with, but that really kind of centres on trying to support parents and deliver phy care as well. Would you mind sharing a bit about that?
Of course, thanks, Chelsea. So my colleague Lauren Daniels, who's the lead neonatal pharmacist at Liverpool Women's Hospital, and we've been working, I've been spending some time at Liverpool Women's just because of the shared care between Liverpool Women's and Alder Hey, but they've got some really great practices that Lauren is leading a great initiative there. So they've got some parent education program that runs with one of their phy care lead consultants, and which includes various aspects of the baby's care, including oxygen, bath, all the different feeding, etc. But medicines features on that about quarterly throughout the year, and the sessions are run, they're advertised to the parents on the neonatal unit, and then they're able to come to the sessions. They're given information about their baby's medicines and some information to take away. And again, as Chelsea and Sean have kind of, it's raising the profile of who your pharmacist is, sort of getting to know people a bit more. Another great thing that they're doing at the Women's is they are processing their TTO, so their take-home medicines are being ordered to as soon as the baby is moving to low dependency unit, and that gives the opportunity for the parents to self-administer the medicines, a selected list of medicines that are deemed appropriate for the parents to be administering. And they have bedside lockers as well, which sort of facilitates that. And when they get issued a parent booklet, when they get given the medicines, and the pharmacist or some of the pharmacy staff would help to have that conversation with the parents about what each of the medicines are for, etc. And then the parents, it's over to the parents then on the low dependency unit with a view for preparing them to discharge, which is much like what the parents in in our Paddington study have described it, what they really wanted to have that opportunity rather than sort of leaving it too close to discharge, and they have a lot to take on, being able to have an opportunity to ask questions, or sometimes you have to do it a couple of times before you realise that you might have a question, or just practice. The more opportunity for them to get involved was certainly welcomed from the parents, I think.
Lovely, thank you. And I think if anybody also on the call has any examples of ways that you've kind of worked with families to kind of get them engaged in that and engaged with the pharmacy specialisms within the unit, then please do share them, because it'd be really interesting to hear a bit more about that. Thank you for sharing, Louise. We've had a question come through, which I think actually was maybe raised, we'd spoken about in advance, actually, I think was raised during the registration process, around prescribing for mothers who have low milk supply. And I was going to pronounce this, but I may do it completely wrong. Is it domperidone? Is that right?
Domperidone, yes.
Right. I wonder, as the questions come through, should we just address that now? Would you be happy to give your comments on that?
Absolutely. I completely share these frustrations. I have attempted in London as well to address this issue that mothers are struggling to obtain domperidone for low milk supply. Unfortunately, at least in London, there is strong objection from our GPs in terms of prescribing this medication. They have concerns that it's an off-label use of the medicine. It's not licensed for this indication. And also there was an MHRA alert a number of years ago. You used to be able to buy domperidone over the counter, but it was removed from the shelves because there is a risk that it can prolong the QT interval, which is a cardiac concern. It does seem very frustrating because obviously a number of these young mothers, they don't have any contraindications to domperidone, they don't have any allergies, they might not be on any medication that would be a concern with domperidone. But in my experience, the GPs feel that the people advising the mothers to take domperidone should be the people who then go on to prescribe it. I feel they feel like they're a bit of a scapegoat in that somebody is advising them to take domperidone, yet somebody else is prescribing it, and they don't want to be that somebody else. And their recommendation to us was that we should get our breastfeeding experts, midwives and nurses, to do a prescribing course and to prescribe it themselves. Now, that might be an opportunity, that might be an option for some of our midwives and our nurses, but currently in our organisation where I work, we don't have any breastfeeding midwives or nurses who have completed the course. But their argument is that it's a short course, it's only 9 months to 12 months. That's the way we should be going. I don't know what other people think about that, but unfortunately, that's the situation we're at least in London. Louise, I don't know if you want to comment on what things are like up in the Northwest.
Yeah, thanks, John. It's much the same in the Northwest, I would say. And Lauren and I had this discussion the other day as well, similar at Liverpool Women's as well as Walter Hay, the same challenges. GPs are reluctant, and the breastfeeding team have been sort of earmarked, if you like, as the most appropriate people to prescribe, but they're often not prescribers. So it's a challenge. So yeah, I'm afraid we don't have a solution for it, unfortunately.
Thank you both. That's really helpful. The follow-up's been, is there an alternative to offer to what we offer with that?
It's tricky, isn't it? Because when you have mothers in the neonatal setting, what we do is we prescribe it for them. So, for example, I'm an independent prescriber. If I've been through, the safety concerns with the mother and none have been raised, then I will prescribe the medication, even though technically it's outside of my scope of practice. I'm meant to be prescribing for babies and children. It's really whether you can find a sympathetic doctor who will do it for you, or a sympathetic non-medical prescriber. But obviously that is only useful for babies who are in your neonatal unit and their mothers are maybe within that area. We know that there is a lot of support needed out in the community as well. And I think those patients are especially the ones who tend to slip through the cracks, because within a neonatal unit, obviously there are prescribers available, even though technically they're the baby's doctors, not the mother's doctors. The other argument was that obstetricians should do it, but I mean, once the mother has had the baby, the obstetrician often walks away. They've done their bit and they're no longer responsible for the patient as they were, because they're no longer a patient, they're a mother. So you feel like you're going round and round in circles, but at least when you have the baby on your unit and you have the mother nearby, then you could maybe persuade somebody on your neonatal unit who's a prescriber to do the prescription for you.
Thanks, Sean. Sounds like quite a tricky balance to weigh up that, definitely. Lovely. Thank you very much for your questions. I think I'm just going to check the chat quickly. Sorry, we're now still talking about Domperidone. Is the increase in breast milk clinically significant after taking this? Is that something that you know the answer to?
I think there's a relatively strong evidence base for it. So I don't think it works for everybody, but within our breastfeeding, support workers definitely would advocate non-pharmacological methods initially. But if you reach the end of the road and none of those have been successful, then yes, we do often initiate domperidone, and in my experience, it generally has a good effect. Like I said, it doesn't work for everybody, but in a number of mothers, they do find it quite helpful.
Thanks, Shan. Yes, I think we've had Zoe also comment on optimising the non-pharmacological measures as well. So great. Thank you all very much. I think, Louise, if I share the video, the Paddington video, just to give a bit of an introduction, and then I'll pass straight on to you if that's all right, to get to share a bit more about the Paddington study. Is that okay?
Perfect. Thanks, Chelsea.
Thank you. Just give me one moment. Oh, actually, I think I haven't shared the sound. Sorry, rookie mistake. One moment.
Usually me.
At least I realised before I press play. Let's do this from the beginning. Okay. That's going to do the same thing to me with the black screen. That's no good. Oh, no, there we go.
No.
Have we got that?
Yep.
Lovely.
Hello, I'm Captain Barker and I'm a pharmacist member of the Paddington Steering Group. I've been a paediatric pharmacist for almost 40 years, with most of my time spent here at Alder Hey Children's Hospital. Throughout my career, I've been a passionate advocate for access to children's medicines. That's fully licensed medicines of the correct formulation and strength, with appropriate supporting information for healthcare professionals and parents and carers. To achieve this, I've collaborated nationally and internationally with a range of organisations, including the UK Medicines Regulator, the MHRA, the Royal College of Paediatrics and Child Health, the Medicines for Children Research Network, and the World Health Organization. Progress has been made, but I believe that the Paddington Project offers a further opportunity to expand and improve the available supporting information about medicines for parents and carers. Not least because the outputs are the result of a research conducted within a formal framework, but because parents are fully embedded within the research team. In addition to my role on the steering group, I was able to conduct some of the early focus groups with families. It was a privilege to hear the stories from the families I met and to learn more about the type of information and support around medicines that they wanted to receive from healthcare professionals, both in the hospital setting and when they were at home. I'd like to thank those families who spoke to me and all of the families who've supported the research. I hope that the outputs from Paddington will be a regular feature in the care package offered to parents and families of babies receiving neonatal care.
Hi, my name is Julianne Brown and I am also known as Mam to my two lovely little girls, Mia who's 8 and Isla is 4. So both of the girls were born prematurely here in the Rotunda Hospital in County Dublin. We knew from early on that I would deliver early due to a uterine abnormality called a bicornuate uterus. Unfortunately, Isla's prematurity was more significant than Mia's. Isla was born at 29 weeks and 3 days by emergency C-section. I remember our first day in home, I was like overjoyed, really thrilled to have Isla home. There was also an overwhelming feeling. How was I going to structure our day and add these medications into our regime at home? Shortly after our time home, Isla was readmitted then to Temple Street Hospital in Dublin for urgent surgery on her eyes. Upon discharge, we had more medications to add to our list. This included pain relief and 2 types of antibiotic drops to be given 7 times a day. It was an extremely daunting time. This really knocked me back. When Isla was about 1 year old, we were at the Rotunda to see the neonatal outpatient team for her review. I remember I saw a survey poster asking, are you a parent or carer of neonates discharged with medications? And would you like to participate in a study to help co-design a resource for parents, carers giving medications at home? I feel it is a huge achievement for me to be involved in the Paddington study, and I wish every success for the rollout of the Paddington Medicines Information Booklet to our hospitals.
Hello, my name's Lucy and I am one of the parents who was involved in the Paddington study. My son Josh was born at full term. He had a pretty speedy unplanned home delivery, and unfortunately we spent some time in NICU when he started having seizures when he was just a couple of days old. In terms of medications, every time we kind of found ourselves in hospital, our medication plans changed. His very first discharge, he was discharged on 4 medications. So one needed to be given at the same time every day, and one needed to be crushed and mixed with water. They were all just sort of slightly different in what we needed to do. It was just, you know, a lot to keep on top of and a lot to manage. So I really do think it will benefit other parents who find themselves, you know, navigating that journey of medications after a hospital stay. Thank you to all the people who were involved in coming up with it, because I think what's being produced is brilliant, and I think it will really help other families who find themselves in this situation. So thank you very much.
Hi, I'm Rachel. My son Hugo was born at 24 weeks gestation. He spent 7 months in newborn intensive care and was finally discharged home to us on home oxygen, on specialist milk, on 8 different types of vitamins or medications. Going home with all those medications was fairly stressful for us, and it became even more stressful when we found, when we went to pick up his repeat prescription, that we found that some of his medications weren't available to be prescribed by the GP. So we had to go back to the hospital. I'm so excited about for the Paddington study is that it both gives parents the resources and information that they will need going home. It gives them that before they go home. They can take it home so they can refer to it whenever they need to. It will give them links to external information that they may find helpful. We are very fortunate. Hugo is now happy and healthy and home with us. We know, I still remember how stressful it is as a parent. So the idea that I can have some input into making things better for parents now and going forward, and encouraging continuous improvement in terms of the care given to babies and the support given to parents. It's really, really rewarding, and it almost makes our journey worthwhile.
Thank you.
Thank you.
Thank you.
Amazing. It's really powerful, I think, the introduction into Paddington. So really delighted that Louise is going to share a bit more with us about this study and kind of working with parents and how this the connection between pharmacy and parents can be hugely impactful for all involved. So Louise, over to you. I hope the tech works. Let's see.
Thanks, Chelsea. Me too. Here goes. Let's try. And I think if nothing else, the parents have outlined beautifully how important this study was and how we've managed to do it. Can you guys see my screen now? Hopefully not got a black screen, but I have lost. Okay.
There we go. Got it.
Excellent. So Paddington, which stands for Parent Co-Designed Drug Information for Parents and Guardians Taking Neonates Home, hence the short title Paddington. And it was a collaboration between a number of different hospitals here, as you've seen and you heard from some of the parents there talking about the different hospitals they were at. So we had 4 centres in the UK. So it was led by Alder Hey Children's Hospital. We also had Liverpool Women's, Leeds Children's Hospital, the Rotunda and Arrow Park Wirral Teaching Hospital as well. And it was a study that was funded by the Neonatal and Paediatric Pharmacist Group. And then we also had some colleagues from the university in Ireland. And we'd been talking, a couple of us had been talking about some issues that we were sort of noticing with parents and struggles when they left the neonatal unit, and we sort of felt that there was something we could do. There was also, it was quite timely, we were at the neonatal and paediatric pharmacist group back in 2019 now, so quite a long time ago. And we actually heard Rachel give this presentation alongside one of your colleagues, Chelsea from Bliss, actually. And they were talking about, they gave a joint presentation about the challenges that parents faced. And Rachel gave an excellent presentation. I sort of heard her describe Hugo's journey there and all the challenges that she faced, mainly on discharge from the neonatal unit. So whilst they're in that bubble on the neonatal unit, they're well looked after and things go well, but then things that could have been avoided, which mainly seem to come back to communication issues, like the issues she described about challenges with the GP prescribing something or having to go back to the neonatal or to the hospital pharmacy to get a particular medication dispensed for her son Hugo. And the lady on the right hand of the screen here is a lady called Julie, who's an Irish parent who joined our parent advisory group as well. So we put out a call on social media for parents to join the group once we had the study up and running. After Rachel spoke, I sort of chased after her, probably looked slightly like a crazy person, to ask her if she'd be willing. We were going to put this funding application into the neonatal and paediatric pharmacist group, and we knew that we couldn't do this study without having parents being able to design and tell us what information they needed. So Rachel, this was one of her slides on the right that she describes her crib sheet, if you like, of what did she need to know. So she had made a list of all of Hugo's medicines, and I don't know how well you can see this, but she's got small and big written next to the medicines, and that was to help her decide which syringe she needed to use. So she'd made her own sort of information sheet, if you like. Scheduling medicines, these were things that she had problems with as well, and some of the other parents alluded to that in the video there with the administering eye drops multiple times a day or 7 different medications. The availability of medicines following discharge, Rachel described that as well, just with her certain medicines in the community and also special milk that Hugo was on. What to do when babies are sick, because obviously babies are sick. It's not an infrequent thing that happens. It happens a lot, and the parents worried about whether they should be giving medicines again. When to stop the medicines, they were other questions that the parents commonly asked, and the lack of knowledge in the community setting, or sometimes the information that had been shared with the GP or community colleagues hadn't quite made it to the GP by the point that the parent was coming for a new supply. So again, a lot of these things stemmed back to communication. And the co-design process. So we were really keen within our wide Paddington team that we would, parents' voice would be central to this. And rather than healthcare professionals sort of designing something that we felt parents need, we really wanted to know what parents wanted to need. So they were integral right from the beginning in terms of even helping us design the information leaflets and the e-surveys that we sent out to parents and healthcare professionals. So our study started with sort of scoping. We thought we would find out what is the scale of the problem or what were the issues that parents faced. So we circulated a Microsoft Forms questionnaire that we shared on various social media, and Bliss also helped us disseminate that to their sort of wider group of parents. We had some of the neonatal charities like Spoons and Neomates as well also circulate. And we were lucky to have 87 parents and carers who responded to the survey. And just over a third of them were administering at least 4 or more medicines on discharge. And that's no surprise to probably anybody on this call in terms of if they go home at the very least with their vitamins and folic acid, then they'd have at least sort of 3 medicines. But also this statistic, the next one, almost half of parents who didn't receive any information prior to discharge, that sort of did surprise us quite a bit in terms of so what was happening to these parents when they were being sent home. Over a quarter of parents reported feeling stressed or anxious about giving medicines, and the majority of them prior to their baby's NICU stay understandably had limited or no experience giving medicines to children. So quite a steep learning curve for them to understand these things. And after our healthcare professional e-surveys, we had a similar healthcare professional e-survey where we had about 155 responses from different healthcare professionals. And after those e-survey results, we got together as a team and we developed our questions for our focus groups. And we asked questions about who should give information, when should the information be given, and what information should be given. And then after this is just some of the quotes that parents had made. So just let you have a little read of those. But you can see the kind of overwhelming themes were parents being really terrified or scared of making a mistake. They had sort of felt that there was lots of moments in their baby's journey to get to discharge, and then They were very worried about giving medicines or what the consequences of making a mistake. And being able to fit things in, they felt like they had a lot going on, and the parents described that beautifully in the video as well. And one parent, something that stuck with me was she described not wanting to go out of the house because she was worried about trying to fit everything in with the specific timings. And many of those issues could have been avoided with some simple conversations with the healthcare team as well to do that. And Google, obviously, we say we shouldn't do this, but people do it. So that was another thing that parents raised, that information sources, which information sources can you trust, which are the reliable ones? So something we wanted to do in Paddington, and as Sean mentioned earlier, the Medicines for Children website, there's lots of good information out there. We didn't want to sort of reinvent the wheel. We wanted to put things together that were already good examples of practice that we could share with the families, but in one place. So we came up with our Paddington resource, our Paddington booklet, which is now hosted on the Medicines for Children website. And this is the sort of front pages of this for anyone who hasn't seen it. And it's got some general advice about giving medicines, how to give medicines to your baby. So things like how to use an oral syringe, how to draw up doses, information about the specific medicines. So we did a survey to the neonatal units within our study, and we came up with a list of the 22 most commonly administered medications, and then tried to link a leaflet back to, so the parents could have a information, as Sean mentioned, some of the medicine information leaflets that are designed by the drug companies, they don't specifically mention pediatrics or neonates. So there are other more appropriate leaflets available. So it was sort of signposting to those things that were already available. Frequently asked questions, they were things that were on Rachel and Julie's list, and other parents told us in the focus group stuff they would like to know, mainly around, could you give another dose? What is the time frame? What happens if baby's sick less than 30 minutes? What do I do, etc. Useful contacts as well. This was something that parents wanted some information about after they've been sort of left the neonatal unit in that bubble. Where do they access further information resources? The medicine administration record was something, this is, I'll show you in a moment, it's basically a chart where the parents would like to have a list of their baby's medicines, and then they almost sign for it, much like a nurse would do on the neonatal unit. And this we had one parent in our study who was a mum to triplets, and she had a really complicated regime for her 3 babies. And she said this would be something that would be really helpful. She had designed her own kind of mini sheet that was stuck up on the fridge, and they were able to manage things that way. And then also some space for notes. So those meetings that they might have with their pharmacy team or nursing team, being able to make notes about what medicines are for, when things are likely to stop as well. We also were conscious about sort of language barriers and thinking if we could simplify information. So by having an infographic, and we worked with a graphic design company to design this sort of infographic for us, just breaking down the stages of how do you give a liquid medicine to your baby, what steps, things like storage, any special considerations as well, and linking back to some videos that already exist on the Medicines for Children website, and a QR code as well, so that people can scan through. This is the list of the most commonly administered neonatal medicines that we sort of put a list together for, and you can click individually on the link. So there is an interactive PDF available on the Medicines for Children website as well, or these brochures are available on neonatal units as well. Frequently asked questions. Here's some of the ones that we've mentioned about further supply, what to do if the GP can prescribe the medicine, or if medicines are only available for a hospital setting. So like Rachel described, if that had been communicated to her beforehand, it would have saved her a bus journey back and forth, sort of trying to get a hold of these medicines. So special medicines that need to be ordered, for example, if parents have oversight of that before they leave the neonatal unit, that's really helpful to them as well. We're also hoping with this frequently asked questions that we would potentially add, it's sort of a list that we may update sort of once a year or so, or twice a year if possible, with new questions from parents. This is the medicine administration records, which it would be populated before the baby is discharged home from the neonatal unit, or the parents can populate it and then stick it up on their fridge and write any information points that they would like to have as well. And as I mentioned earlier, it is now available on the Medicines for Children website. Here's the link if you haven't seen it. We've also got some posters that Medicines for Children had designed with the specific QR codes, because some parents, if their baby's only on certain things, they may want to just dip in and out of various aspects of the booklet, because the booklet's about 20 pages in total. So those QR codes, we've been placing them on our neonatal unit at Alder Hey and Liverpool Women's, just so people are able to scan those and have them available as well. Then we asked, after we'd designed the resources and we had everything, as you've just seen there, we did a another questionnaire to parents who weren't involved in developing the resources, to ask them if it would be helpful, and also to a new group of healthcare professionals. And this was some of the feedback that we got back around how helpful this would have been. These were a couple of the parents who were involved in the study, to just thanking us afterwards about that nobody had shared some of this information. So knowing that would have been really helpful, and particularly stuff around the GP and community issues as well. So it was really nice to get this good feedback too. And that's it. This is just a picture of the team, because the Paddington team is a big team. I'm just here representing on behalf of the team, but it's made up of it's a nice example actually of we talked about multidisciplinary and having a different how we've got neonatologists, neonatal nurses, and pharmacists as well. So and of course our parents. So it's nice to have a multidisciplinary team too. And that's it. Chelsea, back to you. Happy to answer any questions. I'll stop sharing so we can see.
Thank you. Thank you so much, Louise. It's such a fascinating study, and I think really lovely example of working with pharmacists working with parents to really make them feel empowered, which is such a key part of supporting them to feel like they are partners in their baby's care. It's quite an alien, I'm sure for lots of parents, quite an alien situation to have so many medications and going home as well. You don't have the kind of security of the staff around you. So yeah, it really feels like an amazing resource. Have you had much feedback so far, Louise, from people using it? Because obviously, like, I think people can really see the benefit of it, but I wondered whether you've had kind of much coming through from staff and parents who are making use of it now that it's available.
Yeah, thanks, Chelsea. So we rolled it out. We launched our pack almost a year ago to the day. Actually, we launched it last September, and it's been available. Like it was something that we wanted to do alongside the funding that had been given to us from MPPG. So we wanted to make it available to all the units, and we have had multiple colleagues ask us. Actually, in fact, as soon as we launched it, people were saying, "When can we get this?" And we were just waiting for it to be formalised. So it has been. We have had a number of units come back and say they've discharge coordinators, pharmacy teams as well, saying this has been really helpful, and some parents as well on our own neonatal unit. Obviously, we've been using it and had really positive feedback from the parents saying this is really helpful, having something that they can look at and then sort of digest in their own time as well. So sometimes, as Shan mentioned, when they've got a lot of meds, it can be quite overwhelming to think about it. But then by having the booklet and being able to sort of refer back to it, or it can help facilitate a discussion with one of the team as well, which is really good. So yeah, all positive so far.
That's great. Good. Lovely. Please do pop any questions that you have for Shan or Louise in the chat. Otherwise, it's all going to be from me because I've got loads. Is there what's next, Louise? Because I think there's something that's continuing, isn't it? It's developing all the time. So can you tell us a bit more about like what the next stage of that is?
Sure. So that's right. We're already working on Paddington 2. So we've been funded by the National Institute of Health Research for a bigger study. So when we developed co-designed the Paddington resources, they sort of naturally fell into two packs. One is the one that I've just shown you there, which is a parent pack, but we also have a information pack for neonatal units. Now we haven't released that at the moment because we're testing that. We're actually testing how useful that is by running those sessions, and that will take place at 5 centres in the UK as well. So we're in the process of we're almost ready to go live with that. We'll be recruiting for some parents to join our parent advisory group as well, and we'll be having stakeholders, including a multidisciplinary healthcare professional team as well, about how useful it is, and you touched on this earlier, Chelsea, with resource available at different units as well. We appreciate that some sort of smaller units maybe don't have the same staff available to them or time, so just sort of seeing how when we embed the resources, how that would help. One thing that we were conscious of in Paddington 1 was that we didn't have a lot of representation of sort of non-English speaking or a diverse group of parents. So that's something that we're actively trying to do. And we're working with Peter and Josie from Bliss as well. We've got them involved now, formally got them involved on our grant application to help us with that, and your insight and involvement group. So I think that will be really good, because we probably recognise that the parents who, when English isn't a first language, probably have the most issues, and perhaps we're missing many of those parents. So how do we communicate in a more simple, with those infographic type pictures or written written information that they can take away and sort of use Google Translate, or I've been shown lots of sort of cool apps that parents have that they sort of show me that you can scan something and it will read the text back to them. We're also working with vCreate, which is a tech company who can translate into different languages as well. So that's something we're doing at the moment. So we're busy.
Yeah, sounds it.
Yeah.
Sounds it. Kat has asked in the chat whether there are plans to design any apps that kind of goes along with this for parents and professionals to use. Is that something on your radar for the next stage at all?
It's a good question, Kat. We haven't any plans to design an app. There is an app that will be coming out for Medicines for Children in the next, shortly in the next couple of months, I would say. It's just in the kind of final phases of testing. It will probably be that we link into that, but we haven't really felt that an app was something that was needed in terms of, or sort of parents didn't sort of ask for that. And in fact, we thought digital, some group discussions that we'd had within our team were like, oh, digital is the way forward and that's how things move. Parents really liked having paper information. They really liked that idea of having something that you could take away and stick on your fridge as well. So I don't know if we're fully ready to move to a digital world, but maybe when we, it might be something we look at if there's scope for an app after, but we've no immediate plans.
Yeah, I think it's nice, like you've obviously got the option as well with the interactive digital version where you can click through to different bits of information as well. So hopefully that bridges a bit of that gap as well at the moment. Yeah, definitely. Amazing, thank you. I'll keep an eye on the Q&A in the chat in case there are more questions coming through. I think one thing we've mentioned just a couple of times kind of fleetingly is about the fact that we know that capacity and resourcing is different in different neonatal units around kind of this particular specialism, and in fact all of the allied healthcare professionals, it seems the same kind of situation. I wonder whether you have, kind of between you, any sort of advice or thoughts about kind of how staff can bridge that gap and support the integration of pharmacy a bit more into neonatal units if it's not something that is as established on their units, and whether there's any kind of takeaways that you might be able to share about that.
I think peer support is really important, and I think we're recognising that more and more. So for pharmacists out there who are working on neonatal units but aren't possibly members of MPPG, I would strongly encourage them to join. We have a specialist subgroup within MPPG called the Neonatology Specialist Interest Group, which has now, I think, over 130 members. Louise and I are both on the committee of that group, and we have monthly meetings, we run educational sessions. For example, next month we've got a session coming up on metabolic bone disease, and we've run one on the management of reflux back in May. So I think reaching out, and accepting that, especially if you're a lone worker, you might be the only pharmacist in the hospital covering possibly the women's wards, the paediatric ward and the neonatal unit. That's not uncommon. So that's an awful lot for one person to be doing. And, if neonatology is a new thing for you and it's not something you've covered before and you want a bit more help and advice, I would definitely encourage people to reach out and ask for it. There are more network roles as well being developed across the UK. I think there are 11, well, I say network roles. There are 11 ODNs, I think, within England. There's a slightly different setup in Wales and Scotland and Northern Ireland. But for those pharmacists who are working within a network with a network pharmacist, again, I would definitely reach out and speak to that network pharmacist for some help and advice, because that's what we're there for. That's part of our role, is to help support all the pharmacists working within the hospitals within our network. So that would be my advice, Louise. I don't know if you want to add anything.
I think Sian's covered most of it there. That's all really good advice and a great initiative from Sian to set up our neonatology specialist interest group, which she started last year. I think that's been really helpful to people to share stuff that's already going on, because again, it's about, people are busy. If somebody's doing something in one unit, it's helpful to share that information with others. The only thing I would mention that MPPG have some standards about staff for neonatal units, but again, sometimes it just comes down to trust policy and different, sort of other things that doesn't always happen. But there are some standards available about what's the sort of recommended staffing levels. But doesn't always translate into practice, I suppose. I would say we are, as part of Paddington, and we've been given some money from our from the Northwest Neonatal Operational Delivery Network to develop some training as well. So we are in the process of developing an e-learning package, which will be available for all NHS professionals. So where Sian mentioned there, the kind of pharmacists who are just starting out in neonatology, it might be a new thing to them. That could be something that would be helpful as well, just to cover some of the sort of key points in the neonatal setting as well. So hopefully that will be in the next sort of about 3 or 4 months. We should have something up and running for that.
Yeah, and likewise, there's a package being developed on neonatal and paediatric PN. That's hopefully going to be a multidisciplinary package, which will be useful for not just pharmacists, but medics, nurses, dietitians and pharmacists. That is still in the development stages, but we recognise that there is a need for it, that lots of people working in neonatology say that they haven't had enough training in PN and they would like some more. So again, watch this space. It's something that's in the pipeline.
Brilliant. Definitely sounds like looping into the NPPG, if you're not already, is so worthwhile, and that there's lots to come. So that's great. Thank you for sharing a bit more about that. Yes, so Katzel said, will all these packages be available through the NPPG? I assume that's probably the best place for people to go to ask those questions, or to see where the resources are for now.
Absolutely. Yeah.
Perfect. Great. Thank you. We did have one more question that came through, I think, from the registration form about and I think standardizing approaches. It feels like that's come up a few times with different things, but around weaning neonatal TPN. And is that kind of, I just, again, opportunity really to kind of just respond to that question, and maybe more broadly about kind of standardized approaches. I assume that's probably a conversation that you're having at the NPPG as well, about lots of different things.
That is something that will be covered in the pack that's been developed on PN. There's obviously a lot of things that we need to talk about, and it's going to cover both neonates and paediatrics, but weaning will be a topic that's covered. I think currently within not just the UK, but across the whole of the UK in different networks, we're all doing PN, even though we've standardized slightly differently. We've all got slightly different policies. We're all weaning slightly differently. I think if we could get a national standard, that would be incredible. But it will take an awful lot of work, because we all are doing things currently in a slightly different way, and to reach a national consensus on how we should be doing it, I think will be a challenge. But it's something that we would like to aim for, even if we can't get a national consensus, because again, we're not all using the same bags. Even though we're calling them standard PN, we're all using slightly different standard regimens. I think if we could get even a standardized approach across a network, I think that would be a huge step forward, so that all the babies in the network were on a similar regimen, and then they were all being weaned in the same way. That would be fantastic, and like you say, a massive step forward. But I guess what we need is to get all those stakeholders together. I don't know how strong the evidence base for this is, so we're going to possibly just have to thrash out opinions about what is the best thing to do, how is the best way to go about it. And there's an awful lot of people with an awful lot of opinions, but we need to basically get those people together and decide on that, a bit like they do with ESPGHAN. ESPGHAN is a consensus document of experts. We need something similar really for weaning PN, because at the minute we're all doing it in slightly different ways.
Great, thanks, Sian. That's really helpful. Lovely. I think we look like we're kind of haven't had any further questions coming through. So I probably will start wrapping up, I think, because we've learnt loads. I think thank you so much to Sian and Louise for your time in pulling together those brilliant slides and sharing the videos with parent voice in there as well. Is really important for us, I think, to hear just how important it is that we're thinking about these wider roles on the neonatal unit, in line with kind of supporting the babies and supporting the families to really feel empowered and to get the best outcomes. That's ultimately what everybody's here for. So I think you both really helpfully highlighted all of those things. So thank you both so much for your time and sharing your expertise and answering our questions. And thank you to everybody for coming today. And if you're watching back, thank you for taking the time to watch us back. We will be sending out the recording of today with some an opportunity to feedback on this session. So please do let us know what you think, and so that we can continue to kind of grow and develop these kind of opportunities to share learning together. And if you pop your email address as well at the end of that feedback survey, you'll get a certificate I'll send you a certificate just to say you were here. So please do that. That'd be great. I think I mentioned at the beginning, this has been part of a series, and we have some fantastic sessions just like this one available to watch back. So if you have the time, spare time, and you're interested in thinking about other different allied healthcare professional roles, please do kind of use those resources, share with your colleagues, because they're there for you as hopefully useful learning resources or kind of opportunities to really kind of understand a bit more about kind of the wider picture of neonatal allied healthcare professionals and psychology and pharmacy and where that all fits in together. So yeah, huge thank you from me. And let me just, I've got some messages coming through. Let me just double check that I'm not missing any questions before we go. Accessing the Paddington booklet. Louise, would you share, you mentioned that it's obviously on the website. Could you, if you share that link with me?
Yes, I'll share it with you.
Maybe, is that all right? Then I can pop that
absolutely.
in I'll pop that in our email that goes out with the recording and the survey, just to make sure everybody who's kind of signed up for today has it. Is that all right with you?
Great. Yeah, thanks, Chelsea. That would be great.
Fantastic. Perfect. But otherwise, all really positive comments saying thank you, and Paddington looks great, which it does. So there we go. Lovely. I hope everybody has a good rest of the day. Thank you so much.
Great. Thanks, Chelsea, for having us.
Thank you.
Take care.
Okay, bye.
Bye.